All right. Hello, everyone. I'm Nancy Goins. I'm the administrator and executive director of the Forest Park Chamber of Commerce, and we are very happy today to be able to bring you this information all about COVID vaccines and some of the HR that is going to be associated with the vaccines and what implications will be for employers and employees. So, Stephen, how are you? I see you on here. Sorry, I got up for a few minutes and got away. So what I'm going to do is, if that's okay, I'm going to turn it over to you, Stephen, and he's going to introduce our speakers and talk to you about what we're going to do. When Mercy came to us and asked us to partner with them on this, we jumped at the chance, and hopefully Stephen can tell you what our whole thought process is and what they're going to tell us about today. So Stephen, take it away.
Yep. Thank you, Nancy. So for those who I've not met, my name is Stephen Gibson. I am the HR director at Mercy Health Fairfield. And as Nancy mentioned, we are here at Mercy excited to be able to talk to you all about the COVID-19 vaccine and provide that community education regarding it so you all as business leaders can make informed decisions for your employees and for yourselves. So today we have Dr. Stephen Wilson with us. He is a physician at Forest Park Internal Medicine and Pediatrics, as well as myself and Tom Brown, who's from Harness Health Partners. And the goal of today is to have Dr. Wilson provide us with overall education regarding the COVID-19 vaccine. I'm sure everyone has seen various news stories or social media posts with all sorts of information. So we appreciate Dr. Wilson's expertise in this to help us make sure we stick to the facts around the vaccine. Tom Brown will also help talk about, as an employer, what does that process look like from a high level of obtaining a vaccine, if that's the route you're wanting to go for your business. And then I will provide some information regarding the HR processes and policies and what businesses should consider when coming up with their approach for the COVID vaccine. So that's what we'll cover today. We'll pause a couple times throughout the presentation to take questions. Would love to get questions and have some dialogue around the topic we're going to discuss. So with that said, I will turn it over to Dr. Wilson to kick us off.
Well, thank you very much, Stephen. Let me see, who's going to do the slides? Well, great. Well, while we wait, I want to thank you for this opportunity to come talk about COVID-19 vaccines. As mentioned before, my name is Stephen Wilson. I'm a primary care doctor in internal medicine and pediatrics, and I've been practicing in the Forest Park area since 2010. Very excited about the partnerships that we've developed here and looking to grow them. And I think this is just one more opportunity for us as an office and as an organization to share some information that's going to be necessary for the public. Next slide, please. So as we go forward, we're going to talk a little bit about the history of coronaviruses, the impact of SARS-CoV-2, which is the virus that causes COVID-19. We'll talk some about the development of the vaccines, or some of the results of the vaccine trials, and some of the ways that we can increase vaccine uptake in our communities. Next slide, please. So what are coronaviruses? Next slide. So coronaviruses are single-stranded RNA viruses that are commonly found in animals, but occasionally jump to humans. They're named corona because of their crown-like appearance. So if you take a cross-section like we see on the right side of the slide, you have these little spikes that are out there called corona. And these spike-like appearances, when they were observed under electron microscopy, encourage people to kind of call them, give them that name of a coronavirus type pathogen. And these spike proteins are important because that's the target that we're going to use for a lot of treatments as well as the vaccines. Again, these viruses typically just cause common colds when they're in humans, but many of you may remember a couple of rather deadly viruses, SARS and MERS, both which were incredibly deadly. SARS, there were only about 8,000 cases worldwide back in 2003. But 10% of those individuals died. And MERS, which emerged around 2014, there were about 2,400 cases worldwide, but 34% of those individuals died. And this is one of the misconceptions that people have, that that this vaccine that we have now, or the vaccines we have now, were just developed in 6 months. Because of MERS, there was a real concern about the emergence of future pathogens. So there was work being done on a MERS vaccine. Since there were no more cases, it was kind of tabled. But when SARS-CoV-2 emerged, they were able to pull this off the shelf and use this as a prototypical vaccine for coronaviruses. Next slide, please. So what's been the impact? Well, I think the fact that we're all meeting online shows you what the impact is. This virus has been devastating to our community. And we can look at some numbers. We have here the Johns Hopkins Resource Center tracking. These data are probably about 3 to 4 days old, but you can see global deaths are about 2.7 million, and the United States unfortunately leads with 538,000 deaths. Again, these data are from Thursday, so I think this morning when I looked them up, we were up to about 2.8, 2.9 million deaths globally and about 545,000 deaths. Again, number of cases, 121,000 and 121 million, excuse me. And as we see, unfortunately, again, the United States is leading the way with 29 million deaths. This is just tragic. Next slide, please. But beyond the deaths, for those who did survive, there are prolonged symptoms, prolonged respiratory symptoms. Some of the individuals develop diabetes. We have individuals who develop clotting disorders such as strokes, clots, pulmonary clots, heart attacks. A number of individuals have developed kidney failure after COVID-19. There's been this prolonged fatigue and confusion, which some people are calling COVID brain. And we've also seen this widening in healthcare disparities, which has been problematic and something that we certainly need to try to address as we move through this pandemic. But even for those who weren't impacted directly by being infected by COVID, we've had isolation leading to severe depression and anxiety. And I know we've seen a lot of that in our office. School failure, since the kids have not been in school and they've not been able to get online. Many of them are failing, and it's almost been a lost year for a number of our kids as far as educational achievement. Because of the economy, there's been a lot of food insecurity. There's been more domestic violence, increased drug use, and delayed preventative care. The impact of this virus has had on our society is immeasurable, and I think for years to come, we'll be trying to address some of these problems. So it's had a devastating impact on our community and on our society. Next slide, please. But again, I'm hopeful, and I'm hopeful because of the way the vaccine was developed and the way it's being deployed, that we will see some return to normalcy, hopefully in the late summer, early fall, and certainly by 2022. So how was this vaccine developed? Next slide, please. So this is an important person to know. This is Dr. Kizzmekia Corbett, and she's a virologist who got her PhD at UNC Chapel Hill. And upon completion of that, went to work at the NIH at their viral pathogens lab. And she's worked directly for the last 6 years on developing a vaccine that would attack MERS. And when, again, MERS no longer existed and we saw the emergence of SARS-CoV-2, she was able to use that research that they had for MERS and incorporate it into a vaccine that could be used to prevent SARS-CoV-2. She developed a strategy for the Moderna vaccine, which is the mRNA 1273. And the way she describes her approach is she needed a vaccine or a platform that was going to be fast, reliable, and universal. And we'll talk about why mRNA vaccines fit that bill. Next slide, please. So again, they used MERS as a prototype pathogen because, again, it was very deadly. There was fear that it was going to spread, and there was a definite need to develop a vaccine. While we didn't find any more cases after 2014, there was a thought that we needed to keep this technology available for the emergence of another virus, which we saw in the form of SARS-CoV-2. So once she identified the amino acid sequence for that spike protein that we talked about before, she could use that to develop an mRNA sequence, and we'll talk about why that's important, to code for that spike protein. And then once you had that mRNA, you could put it in a what they call a lipid nanoparticle, which is not a robot, it's just a small fat particle, and deploy that as the vaccine. Again, mRNA is very easy to make and can be made over the course of several hours, whereas if you were to try and make the protein, you would need other organisms, and it takes days to weeks to make. So the mRNA type vaccine is very fast, and again, it can be adapted very quickly. And as we see on the right side of the, you go back to this next slide, please. Back. So as we see on the right side of the screen, that's an electron micrograph of the MERS coronavirus. Next slide, please. So how do the vaccines help develop immunity? Next slide. So we're going to do a little bit of biochemistry. So I hope I don't scare anybody. Just a very little bit of biochemistry. So we know that DNA contains our genes, and the genes give instructions to the body on how to make proteins. Proteins to form your skin, proteins to form antibodies, proteins to form enzymes that allow your body to function, a host of proteins. Well, the way the body gets those instructions and utilizes them, the DNA is what we call transcribed to something called RNA. And the RNA takes the message from the DNA out of the nucleus of the cell into the cell, what we call cytoplasm, and it combines with something called the ribosome, which actually reads the RNA and converts it to a protein. Next slide, please. This is what a ribosome looks like, and a ribosome is made up of protein and something called rRNA. As you can see at the bottom of the screen, you have the mRNA sequence. The ribosome attaches to it and basically reads that mRNA, and based on the sequence of those, what we call bases, it will allow a different amino acid to attach in a particular order. And you form something called a polypeptide. And that's simply a sequence of amino acids. It's not quite a protein yet because it has to be prepackaged so that it has the right structure and orientation. But once we are able to read that RNA, you make that polypeptide, which again, we can turn into a protein. And that's how the mRNA vaccine is going to work, or it works. It gives the sequence of the spike protein, allows the body to read through that ribosome, makes that polypeptide, and then the body thinks it's a regular protein that it's supposed to make and packages it up and puts it on the surface. And then that's how the body recognizes that. And we'll go to another slide that talks about that. Next slide, please. So for the COVID-19 mRNA vaccines, basically, the mRNA is encapsulated in a lipid nanoparticle. Again, nano doesn't mean robot, it just means small. The lipid nanoparticle is basically a small layer of fat that encompasses the mRNA. One of the reasons that it has to be stored at such a cold temperature is because while mRNA is easy to make, it is very fragile. And at room temperatures, it breaks down pretty quickly. So by storing it in that fat lipid particle, or that fat nanoparticle, and then keep it in cold storage, it's able to hold until it's able to be deployed as a vaccine. So the mRNA is injected into your deltoid or your shoulder muscle, and you can see there's the lymph nodes. The lymph nodes are the organs that contain the white cells that are going to help us promote the immune response. And we'll talk about in the next couple slides. Next slide, please. So as you can see up in the upper left, you have the mRNA 1273 lipid nanoparticle. It's floating around in the bloodstream, and then it attaches to a cell. Once it attaches to the cell, the mRNA is released. The ribosome picks it up and starts reading that mRNA to form that polypeptide for the spike protein. Then that spike protein goes into something called, the polypeptide goes into something called the endoplasmic reticulum, which basically packages it up and changes its orientation so that it can be deployed on the surface of the cell, which you'll see over on the right side of the screen. That spike protein is sensed as being foreign to the body. And by being foreign, The body wants to deploy cells to come and figure out what it is, figure out if it's friend or foe, and if it's foe, certainly attack it. Next slide, please. So this slide is just a larger view of that. And you have something called the CD4 helper cell, T activation. So this cell is sort of the brain trust of the immune system. What this cell will do, and you can see a couple of arrows, one going down to the B cell. Once it identifies that protein of the spike protein, it'll activate the B cell. The B cell will say, this looks foreign. Let me create some antibodies to go attach it and attack it. And those are the so-called neutralizing antibodies for SARS-CoV-2. You see the arrow going to the top, it also forms and activates some what we call CD8 cytotoxic cells. These cells sense when one of our human cells has been infected by a virus, and they go and kill it, basically, because they don't want the virus to use its own cellular function or machinery to replicate. So if it senses that there's a cell that's been attacked by the virus, it goes in and kills it. So between the cytotoxic cells and the B cells promoting antibodies, all those come together to try and promote an immune response in case you were to get infected. Again, since this is just mRNA, there is no virus, but the body doesn't know the difference and says, we're going to create some cells, one, so if the virus does come, we will destroy those cells that it's trying to use to replicate. And two, we're going to have some antibodies. So if we sense it anywhere in the blood or on what we call your mucous membranes in your mouth, your nose, those antibodies are going to go to attach to that virus and allow us to get rid of it. And lastly, in the upper right corner, you'll see something called memory T and memory B cells. And this is one of the really great things about the immune system is once it sees something, it's going to remember it. So it's going to make some memory cells to kind of put in storage because those cytotoxic cells and those B cells are going to eventually die and go away. But those memory cells are going to stay around a little while. And if the body ever is exposed to that same pathogen, those T cells and B cells activate quickly and boom, they identify the pathogen and eliminate it. I want to stop there and see if there's any questions before we go forward. I know we went through this a little quickly. No questions? Oh, I should be teaching at Harvard. Okay.
I have a question, of course.
Absolutely.
So when they have these memory T and B cells, is this similar to the cold? Like if you have a cold, do those help this or not? Because how come we can't, there's still no cure to the common cold?
Absolutely. Good question.
Right.
So one of the things, these memory and T cells and B cells work for a specific virus. And one of the things that we find is that cold viruses change so frequently that it's difficult for the body to keep up. A good example of one that doesn't change is like varicella or chickenpox. Once you've gotten the chickenpox, you rarely get it again. There have been some rare cases where people get chickenpox again. Now, you may get when you're a little bit older, but these T cells would help eliminate the varicella virus if they saw it again. And others would be measles or mumps or rubella, viruses that are very, very stable. Cold viruses and another common virus, unfortunately, HIV, tend to mutate pretty quickly. And viruses that mutate, the T cells and B cells can't keep up with it because they'll see it and they'll have a specific pattern that they're looking for in that particular virus. But if there's a mutation, they don't see that virus as being the same one that they were developed to fight. So they let it go and it's allowed to infect the body again. Does that make sense?
Is there a difference between this virus? Are there different, I mean, I know they keep saying there's variants, but so many people have so many different symptoms.
Right.
Are there differences between the two, any virus, like a mild case and then one that obviously, there's plenty of bad cases, but then there's so many mild cases too.
Yeah, and it's not clear why certain people, and that's one of the challenges with this virus, it's not clear why some people are either asymptomatic or very mildly symptomatic, and others develop severe disease requiring hospitalization, ICU, admission, intubation, and that leads to death. And that's one of the things I think we are trying to figure out. Now, the variants that we see, we think the vaccines will help cover us for those. Now, certainly, prior infection doesn't always cover you for the variant. And one of the prime cases of that is down in Brazil. One of the reasons that we found out about the P1 variant, which was first identified in Brazil, is there was an area that we thought 75% of the people were infected with SARS-CoV-2 and got COVID-19. And then 4 to 5 months later, a number of people started getting reinfected. And when they were testing positive. And we were like, well, wait a minute. These individuals tested positive, so why are they testing positive again 6 months later? And then that's when they did the sequence, and they found that there was a variant down in Brazil, and they also found some variants that were first identified in South Africa and the UK. Again, because of the mRNA sequence of the vaccines, we think that the vaccine response, the immune response, is going to be much greater than you would have if you had a general infection, so 5 to 6 times greater immune response. And 2, the vaccine also looks at a broader part of the protein to attack versus what the body would find. So we think that it may give you a little bit longer protection than having infection. But the variants are concerning. And talking with some virologists, this virus, SARS-CoV-2, doesn't mutate as quickly as some other viruses. Like HIV mutates very quickly, which is why we haven't been able to come up with a vaccine for that. But it does mutate enough where people have been able to get a second infection, and that's why it's so important to get people vaccinated. Because you can think of mutations as being basically mistakes. When the virus infects you, there's going to be some mistakes it makes when it replicates. Most of them are going to be useless, but there's certain mistakes that may actually allow it to be more infectious, maybe attach, maybe to evade the immune system. So the more people that you can get vaccinated, the fewer times you'll have the virus will have an opportunity to mutate and to form a variant. Any other questions?
Yeah, I had a question. It's about you were in the list of effects, and not just the individual, but as groups of people. You had like isolation, anxiety, depression from social distancing and having to stay at home, that sort of thing. Is that something that's getting better as time goes by, or is it? Because if I look at personally, to the extent that I felt those things, it was more at the beginning than now.
So
you make adjustments,
Yeah. So what I saw, and particularly in our practice, the first, like last March, about a year ago, people are kind of enjoying spending some time at home. They're like, okay, go home. I'm going to be able to watch TV. I'll do a little bit of work. I'm going to be fine. And I've actually had some patients who they thought they would love working from home because they didn't particularly socialize with their coworkers, and they were kind of loners, and they went crazy. I mean, one in particular, she we didn't have to put her on any medication, but we had her meet with our psychologist. And the thought was, you need some interaction. So she started going to work a half day a week. And just that alone really helped her recover. We found some people who thought, okay, this is going to be my way of entering into retirement. And after about 2 to 3 months, again, they just couldn't deal with it. They're like, I got to have that interaction. So what I saw was really around the summer, when things started to open back up a little bit, except here in Hamilton County when the mask mandate came first. Usually around that June, July is when I really started to see people deteriorate. And certainly through the fall, and in December and January it was really, really bad. Now, I do see some improvements now. I think more people are getting vaccinated, and grandparents are able to actually hug their grandchildren, and they're able to kind of interact with their colleagues who've been and friends who've been vaccinated. So I do see things getting better, but I think I really saw the nadir around the July, June, August timeframe.
Thank you.
Mm-hmm. Any other questions? Okay, let's move to the next slide, please. So, how efficacious and effective are these coronavirus vaccines? And I would say vary. There's differences into the degree of which they're effective, but I would say overall they're very effective. Next slide, please. We'll start with the mRNA vaccines because those were the first, and actually those have probably had the best data. Again, there's been extensive research on using this technology for coronaviruses. Again, this started with MERS back in 2014. The nice thing about it is, again, the technology is very adaptable, allows for quick deployment. The one thing, and it's still the case, that no vaccine has been officially licensed using this technology. Both the vaccines that are in use have been given emergency use authorization. I will say these vaccines have been used in more people than probably any other vaccine that we've had in history. Right now, as of today, I think there were 127 million of these two vaccines that were deployed within the United States. So I anticipate licensing coming soon because with the number of people who've been vaccinated and the rare number of side effects that will go through licensing soon. But right now, they have just been given emergency use authorization. Next slide, please. And the nice thing about the mRNA vaccines and the studies that were done, they were very clean. And we'll talk about a study when we talk about viral vector vaccines that weren't as clean. Both of these vaccines, both the Moderna, the mRNA 1273, and the Pfizer BioNTech, or the BNT 162b2, were done in randomized trials. The Moderna vaccine was pretty much a US-based trial. The Pfizer was more of an international trial with US, Brazil, South Africa, and Germany as participating countries. Both had over 30,000 participants. And I will tell you, most vaccine trials probably have about 10,000. So these are 3 times the number of participants that you would normally see in a vaccine trial. Both were 2 doses. The Moderna was given 28 days apart, Pfizer 21 days apart. Both the subjects were followed for about 60 days. And what was the nice thing about this new technology, because again, it was not used, no other vaccine has been licensed using this, is you got very similar results. For the Moderna vaccine, you had 185 cases in the placebo, 8 in the vaccine, which going through some calculations gave you a 94.1% effective. And with the Pfizer, it was 162 cases, 8 in the vaccine, 162 in the placebo, which gave you 95% effective. And again, for severe disease, which they would say anyone who had an oxygen level less than 93, all the way through hospitalization, ICU, intubation, and death. On the Pfizer, there were no cases of severe disease. And in the Moderna, there were no cases of severe disease. And on the Pfizer, there was one case, there was one individual whose oxygen level dropped below 93% for, I think, a couple of hours, but none of them, no cases in the Pfizer had hospitalization, ICU admission, or death. So they're 100% effective against hospitalization and death, and that's why they're so clean. The Pfizer vaccine probably took a little bit longer to get through emergency use authorization, but the Moderna actually went through much quicker because it was second. And I think they're great vaccines. I got the Moderna, my wife got the Pfizer. We're both doing well, and we're very excited about it. I think, again, this is a new technology that I think is going to be very useful as we go forward, because SARS-CoV-2 is certainly not the last coronavirus we're going to see. And having something that's going to be very adaptable, like these mRNA vaccines, and also very quick is going to be great. Next slide, please. So the next group of vaccines are the viral vector vaccines, and you've probably heard of these on TV. There's the Janssen/Johnson & Johnson vaccine and the AstraZeneca. The viral vector vaccines, they work by taking a virus, particularly an adenovirus, and altering the genome or the genes so that it can't replicate. But then you insert the gene for the spike protein in there so that when the virus enters the cell, that DNA will go into the nucleus. It will not enter the individual's DNA, but will go into the nucleus and use the cellular machinery, as we mentioned before, to make RNA through transcription. That RNA will go out into the cell and make the spike protein using the ribosome, and then that's how you're going to form the spike protein and generate the immune response. One thing I can't emphasize enough is the DNA does not enter what we call the human genome, so it does not alter your DNA. Now, this platform has been used for the Ebola virus vaccine, and which has been licensed in the European Union. But other than that, it has not been widely used either. And you've probably heard Johnson & Johnson/Janssen, which is the European subsidiary, was granted emergency use authorization for this vaccine. Next slide, please. So with the Janssen/Johnson & Johnson vaccine, this was an even larger trial, had 43,000 participants, multi-continent, so it was in the US, Brazil, Mexico, South Africa. It is a one-dose vaccine for now. Johnson & Johnson has an ongoing study for a two-dose vaccine study, and I think there's some thoughts that you might need a booster at some point. At this point, though, it is licensed as a one-dose vaccine. Again, this had a very diverse population with communities with a lot of SARS-CoV-2 variants, as you can see with Brazil and South Africa. Patients were assessed at 14 and 28 days after their injection. And when you look at the overall efficacy, 66 is not 94%. Now, it's difficult to compare them directly because they were in different populations, et cetera. But that was one that caused some people to take pause. Having said that, when we go down and we look at the bottom, it is 100% effective at preventing hospitalization and death, which is what we want. So in the United States, it was 72% effective, Latin America, 66% effective, and in South Africa, it was 57% effective. Again, that's just for mild to moderate disease. When we look at severe disease, again, going from decreased oxygen all the way to death, it was 85% effective at preventing severe disease. And particularly when you look at the B.1.351 variant, which was first identified in South Africa, it was 89% effective at preventing severe disease. And again, at the bottom, 100% effective at preventing hospitalization and death. So it is a very, very good vaccine. There may be people who get sick with it, but it does prevent some transmission. And we know it's not going to make you sick enough where you have to go to the hospital, and fortunately not having to go to the morgue. So again, another great vaccine that's got an emergency use authorization. They are having some manufacturing issues, so we don't have the number of doses that we would like, but I think that's going to improve over the next 6 weeks. Next slide, please. This is the one that's been in the press a lot. And the information I was sending to Steve Gibson on Thursday, I kind of knew that things were going to evolve over the weekend. I was going to have to keep up with what was going in the media. We'll briefly go through this slide, then I want to talk about some of the things that have gone on within the past 24 hours. So this was another vaccine that was pretty much developed over in Oxford in Great Britain, and they partnered with AstraZeneca to deploy it. This was a multinational controlled trial as well, with a number of countries, United Kingdom, South Africa, Brazil. For some individuals, they would, instead of using placebo, they would give the meningitis vaccine, which was great. And initially it was administered as a 2-dose series. SD stands for standard dose, 4 weeks apart. Well, they had a manufacturing error. And part of the manufacturing error were there were some doses that were released in the study that were actually half the concentration of the standard dose. So, and they didn't realize that till after they had been administered. So you had some people who got the half dose and they said, well, we're not sure if we should come back with the full dose at 4 weeks. So let's do the full dose at 12 weeks. So some of those individuals who got the low dose, which LD stands for, but then they got their second dose for the standard dose at 12 weeks. And you could try to compare those with individuals who got 2 doses of the standard dose 4 weeks apart. Well, the results were kind of interesting. When you looked at the overall efficacy, it was 70%, which that's reasonable, very, very consistent with what you saw with the Johnson & Johnson vaccine. But then when you started breaking it down to those who got the standard dose and those who got the low dose, those who got both standard doses, their efficacy was only 62%, yet those who got the low dose and followed by the standard dose, they got an A. And so that's making you wonder, okay, why is the lower dose more efficacious than the standard dose? And, why is it waiting 12 weeks versus giving it after 4 weeks more efficacious? And that became confusing. And my dad used to work for the Food and Drug Administration. Anybody who's familiar with the Food and Drug Administration, they don't like confusing. If they're confused, it's going to be a hard stop. The other issue with this is that the participants who did the best in the low dose and standard dose, none of those individuals were over 55 years of age. So you're not clear if it was better because it was a healthier population, fewer risk factors. Having said that, it was 100% effective against hospitalizations and deaths. So nobody who in the vaccine group, whether you got the standard dose or low dose, died or had to be hospitalized. And it did get approved in the UK. Now, of course, it's going to get approved by the UK because they were the ones that discovered it and deployed it, but it also got approved by the World Health Organization. This last point has probably changed a little bit. Still, South Africa is not using it because they didn't find it as effective, particularly for their B.1.351 variant at protecting against mild to moderate disease. I think Germany and France and Denmark are starting to allow the use of it again. They put it on pause. The problem that you're having with Germany and France, though, is the populations are a little reluctant to take it because of what they thought was an association with the development of blood clots. And then there was some information that came out a couple days ago, I think it was either Sunday or Monday, where the AstraZeneca Oxford vaccine released through a press release that their vaccine, I believe it was 80% effective at preventing disease. And they were going to go for emergency use authorization. And then this morning, I was watching on CNN that the Medication Monitoring Safety Board basically called AstraZeneca out and said the data they presented aren't accurate. So this is a mess. It's really a mess. The fortunate thing is we have enough vaccine between Pfizer, Moderna, and Johnson & Johnson to cover the US population. But we do need to figure out what's going to be the best dosing strategy and what's going to be the best way to administer this Oxford AstraZeneca vaccine, because this is a vaccine that can be stored essentially at refrigeration temperatures. It's very cheap to make and would be something that we need to deploy widely across the world. So I think the UK has found that it's really helped them because they're not seeing the rise in cases like the rest of Europe, particularly in Germany and Italy and France, where they're about to go through lockdowns. I don't believe Germany is having that. So it is shown to be effective, but we need to figure out kind of what the strategy is going to be. Let me pause there. Any questions? Okay, next slide, please. Let's talk about vaccine uptake. Next slide. Early on, we noted that there were some startling racial and ethnic disparities in vaccine acceptance. And if you look at the box that's highlighted in red, you'll see back in December, that 20% number represents the number of African Americans who've gotten the vaccine or will get as soon as possible. And you can see it was only 20%. And when you look at the box all the way over to the right, where it's the white population, it was 40%. Now, both did go up. African Americans getting the vaccine as soon as possible went up to 35%. And for white Americans, it went up to 53%. But that's still a startling discrepancy. And I think there was certainly some discomfort about the vaccine, some discomfort of rollout, the discomfort of how quickly it was developed, although as we've talked, it did take place over the course of years. And I think that's where some education was required. Next slide. But there have been some startling changes and some things that have surprised me. This slide represents a study that was done later in January, and it was done a survey of African Americans, adults. And while the overall acceptance of the vaccine was about 49%, which again, I think that's lower compared to what we'll see, and I'll show another slide on that. Really, when it comes to Black Americans that are over 60, the acceptance rate was much higher. It was 68%. And something that surprised me, but I've seen it a lot in my population, African American men were much more likely to accept the vaccine than African American women, 78 to 59%. Again, I think that's changing, and I'm seeing more African American women accept it. We'll talk about why there were some reasons for that. But clearly, African American men were at the high end of wanting to get this vaccine. And I think we're still at the pace where demand outpaces supply. So as we continue to get more and more vaccine out there, we'll be able to get more and more people vaccinated. Again, it's the young African Americans, 18 to 44, 41% did not plan on getting the COVID-19 vaccine, and we'll talk about how we can improve that. But again, that 45 to 59, which is even a larger gender gap than we saw for African Americans over 60, 75% of Black men wanted to get the vaccine versus 43% of Black women. Next slide. So this is another slide, and this is probably the most recent data I can find from the Kaiser Family Foundation on vaccine acceptance. And I think if you go all the way to the bottom where it says 65 plus, Black adults and white adults, if you take the dark blue line and add that to the lighter blue line, so in the case of African Americans, it was 35 and 46%, and for white Americans, it's 46 to 30%. You can see, again, the acceptance rate for individuals over 65 for African Americans compared to whites are pretty much the same. African Americans may have a little bit greater acceptance of the vaccine. Even when you go to 50 to 64%, there's not a huge difference. 13% plus 38% of those who already got it or get it as soon as possible versus 14% and 48%. There's not that huge a difference. It's that 18 to 49, again, that we have to work on, that particularly African Americans that are under 50 are very hesitant to get the vaccine. And there's some reasons that we could talk about for that. Next slide. The big thing is, I think, again, the concern about the short timeline with the vaccine, which again, particularly when you look at the Moderna vaccine, and Pfizer has a similar story where they had been working on a vaccine for years, and because MERS or the coronaviruses weren't emerging, it kind of got shelved. There's actually been a lot of work done on these vaccines, these mRNA vaccines over years, and also some of the viral vector vaccines. So the short timeline is probably not completely accurate. There are concerns about vaccine safety and side effects. I would say at this point, particularly with what we've been seeing with the Moderna and the Pfizer vaccine, you've got 127 million people who've gotten at least one shot, minimal side effects. We've had some people who've had some anaphylaxis, but again, those individuals, that's why you have to wait 15 or so minutes after you get your vaccine. I think those are things that we can manage. And those who've gotten the vaccine probably notice some pain, some fatigue, maybe some chills. I tend to have found people who are a little bit younger than I am, and I'm 53. So colleagues, particularly who are in their late 30s and 40s, struggled a little more than I did. But even then, they were completely back to normal after about 36 hours. There's concern about the vaccine efficacy. Well, again, the main thing, they all work at preventing hospitalization and death, which is what we want. There may be some people that get a little bit sick, and that's okay. As long as we can keep people out of the hospital and keep them out of the morgue, I think the vaccine has done its job. And then there's some people who are not concerned about getting COVID. I think those numbers are dropping as we've seen more and more people get COVID, and particularly younger people with some of the variants that are out there that are suffering some of the hospitalizations, some of the deaths, and then some of the long-term symptoms. But I think these are valid reasons why people are concerned about them. But I think by conveying some of the information about what actually is the timeline, or was the timeline, what are the side effects, and what the efficacy is, hopefully will change some people's minds. And again, one of the things that I've done a lot for patients of mine is they don't want to get it because they don't feel like they need it to protect themselves. But we start having conversations about protecting loved ones, protecting their parents, protecting spouses who may have chronic illnesses that put them at risk, protecting children who may have chronic illnesses and the COVID would put them at risk. So doing it for your loved ones if you're not going to do it for yourself. Next slide, please. So some of the strategies that we have for increasing vaccines is one, acknowledging mistrust amongst African Americans and other populations about treatments and vaccines, and being honest about it, that there have been some injustices that have occurred in the past, but that our communities have been involved in all the development of this particular vaccine and these vaccines, and that they are safe. And we need to engage African American physicians, politicians, church leaders, community influencers, all these individuals about safety and efficacy, provide data to them, which is something we're trying to do today, and then discuss the consequences of acquiring COVID-19. And I think, again, one of the reasons that I think I keep hearing from a lot of my African American patients, particularly men who are over 60, is they say they want to get it because they want to travel. Because I think there's a big fear coming that if you don't have the vaccine, you may be able to travel, but you're going to be getting tested on a regular basis. And anyone who's been tested knows that it's not comfortable. Next slide, please. And just briefly in closing, because I know I have to leave Steve some time. Some of the misunderstandings, there's one that's been pretty popular out there that's false. Vaccine causes miscarriages. While there were no pregnant women that were allowed in the study, there were women who got pregnant in the study. There were actually more women who got pregnant in the vaccine arm of the study than who got in the placebo arm. It was much, it's like 13 versus 11, but so it doesn't cause miscarriages. Doesn't change your DNA, and we talked about that. Vaccines don't cause COVID, and because there's no live virus, or in the case of the viral vectors, it doesn't replicate. The vaccine will not cause you to have a positive test. We do believe that the vaccine prevents transmission, and we do think more work needs to be done, but we do think that the vaccine does protect against the variants. Next slide. And I just want to acknowledge some of my friends and colleagues who shared some slides with me. And with that, I'll stop, and I think I'll go ahead and turn it over to Mr. Gibson.
Thank you, Dr. Wilson. So once again, my name is Stephen Gibson. I'm the Director of HR at Mercy Health Fairfield. And I'm going to walk through some of the implications for HR policies for your business as you think about the vaccine and your approach. So go right ahead, Nancy, to the next slide, please. So I do want to start out with a disclaimer that I am not an attorney, and I am sharing information from the Equal Employment Opportunity Commission, as well as the Society for Human Resources Management. So as you're looking to implement any policies, any approaches, absolutely speak to your legal counsel, as things are changing rapidly every day when it comes to the vaccine and COVID. So just want to make sure I put that disclaimer up at the front. Next slide, please. So the first question that is mostly out there is, because this is an emergency authorization for the vaccines, can an employer require their employees to obtain the vaccine? And the answer is yes. The EEOC has said that you can lawfully require your employees to receive a vaccine. However, you must consider exemptions for religious and medical accommodations. This is very similar to the flu shot vaccine as that rolls out each year and giving the employers the opportunity to require it. Next slide, please. So as businesses evaluate, should I make it mandatory or voluntary? There's multiple areas that they should consider when developing that strategy. One is looking at the societal, political, and ethical considerations at the time. So the vaccine and COVID has been a very political conversation over the last year. And business owners need to weigh, is this something good for my business? Is this the route that I want to go, giving all those different considerations? You also want to think about, do you have unionized employees, or what's your unionization risk should you make it mandatory? Also wanting to consider vaccine availability. If you make it mandatory, but not all of your employees can access it, that will cause challenges to your business. The administrative burden is also a part, as thinking through, how do you record keep who has received it, who hasn't received it? Are you going to pay for it? So all those administrative tasks that go along with administering the vaccine would need to be thought through. And then also managing your employees' fears. As we said multiple times, the emergency approval has created a lot of fear amongst employees, and that needs to be taken into consideration as you navigate what should your approach be. Slide, please, Nancy. So this is a survey that the Society of Human Resources Administration did for employees at various businesses across the country that said, why won't you as an employee get vaccinated? And you can see the number one reason is, I'm concerned about possible side effects. And then you can also see in the next line down that they just want to wait and see if it's safe and may get it later. And that's something we're hearing a lot in my HR circles and my own organization, say, I think I will get it, but I really just kind of want to see how this goes. So that is a great feeling out there amongst employees that businesses would need to think of. I won't go line by line, but you can see there are various reasons why employees might be hesitant in order to obtain it, which should factor into your decision as a business leader. How do you want to structure your approach? Next line, please. So if you choose to make it mandatory, there's two pieces that you would need to make sure you have built into your policies and procedures. Those are the religious exemptions as well as the medical exemption. And the religious exemption is, once an employer is basically given notice that employee has a sincerely held religious belief, practice, or observance prevents the employee from receiving the vaccine, they must provide a reasonable accommodation. With medical exemptions, if an employee indicates that they are unable to receive it due to the vaccine due to a disability, you then have to look at, does a direct threat exist to your business if you cannot accommodate that? So what's the duration of the risk? What's the severity of potential harm that could occur to your business? If it is determined that there is a direct threat, organizations will need to build into their policy, how do we look at reasonable accommodations, whether it's providing PPE or telework options, work from home. So there will need to be creative solutions to work through with your employees to determine, how can we make this work while following medical exemptions under the ADA. Next slide, please. So a couple things that are important to know is, if you roll out vaccines in your organization, you might have employees say, hold on, this is crossing over to some sort of medically related thing you're not able to do. And it's important to say that the COVID-19 vaccine approved is not considered a medical examination in order to have it administered. The second piece is, you are able to request proof or receipt of a COVID-19 vaccine as long as it's not a disability-related inquiry. So one of the areas that can get businesses in trouble in this category is if someone says, I'm not interested in receiving a vaccine, and then you say, well, why aren't you receiving it? That is opening the door to a medically related inquiry, which could then be falling to the category of a disability. So business leaders, organizational leaders need to be very careful what they ask when it relates to, why are you not receiving a vaccine? Next slide, please, Nancy. So I wanted to talk real briefly about Mercy Health's approach, just to give you, from a health system perspective, how did we look at rolling out our own vaccine. So we chose to go with a voluntary participation, making sure people knew that we strongly encouraged and we believed in the science and we believed in the vaccine's results through the studies. However, we took all those considerations into place that I had on an earlier slide to say, how do we navigate this with our employees? How should we create policies and procedures that get them really the right information? So the screenshot is actually from our intranet, where we chose to say, you make your own decision, employees, but we're going to make sure you have credible information. We want to make sure we point you to resources that are linked to external organizations or even our own clinicians, such as Dr. Wilson, speaking about the science behind it and making sure that they are fully educated, so then they can also educate their patients and their family members in the community. So we did not feel that we needed to do mandatory participation, but we really wanted to go from the fact of let's educate, inform, so that you can make the best decision for you and your family. We were also, as a healthcare organization, because some people could say, well, if you could have made it mandatory because you're working with patients, there is a direct threat. Well, we were fortunate as an organization to be very well equipped with PPE. So that was one of the areas that we felt that was not a direct threat, that we were allowed to say, you can make that decision because we have things in place to protect you as well as our patients and visitors. And that was important to our approach. So we internally built, like I said on the screenshot, links to educate so people got credible sources of information that they could easily access. All right, for the sake of time, I'm going to turn it over to Tom Brown real quick to talk about as a business. And I think right here, Nancy, we probably can stop on the slides. I don't think Tom has any, and let Tom talk about what his team has done with helping businesses navigate the vaccines.
And thank you very much, Stephen, and thanks to everybody here as well. Just a few quick notes. Harness Health Partners is actually the employer solutions division or arm of Mercy Health. And over the past few months now, we've been working across many different states directly with employers who have been looking for ways to communicate with their respective departments of health to register to receive vaccine on behalf of their employees. This has been mostly with organizations that have been deemed as essential. And of course, those vary from state to state as well. As we see communities, and especially recently here in Ohio, with vaccine availability apparently increasing, we really do think that communities will have access much more quickly in Ohio than perhaps in other states. But we have been working very closely with larger employers to help on their behalf to receive vaccines, store it appropriately, get it into arms, and do all of the associated reporting. But one thing I want to call out separate from that, because it was raised on a couple questions here today, was some of the things that might, the other impacts of COVID-19, which is that behavioral health and some of the challenges around that. And I'd like for Taylor Newlove-Chimes, who's one of my colleagues, to speak to a program that many of you may already have access to as part of your benefits, but something that you may want to closely consider if you are seeing or are concerned with some of those impacts around emotional and behavioral health. And Taylor, if you wouldn't mind speaking to that real quickly, that would be great.
Yeah, absolutely. And thank you all for your time today. We are really grateful to Dr. Wilson for being able to share this message with us all as we continue to be advocates in our communities. But to Tom Brown's point, as Harness Health Partners, the employer-facing division of our organization, our focus continues to remain helping you optimize the health and well-being of your workforce with our return to work strategies that we're doing now with our COVID-19 testing and vaccination strategies to helping you manage the health and well-being of your workforce, but particularly in the areas of physical and emotional well-being. It's interesting, the question came up earlier about what is emotional health and mental health looking like where we are today in the pandemic. And the American Psychological Association actually just recently released a report. They released it in March 2021 based on a survey that they did in February of this year, really looking at, what's going on now that we're approaching 1 year of being in this pandemic. And, they're really seeing in those numbers the impact that COVID-19 is having on our physical health as well as our emotional health. And physical health being, changes in sleep patterns are prevalent, as is obviously weight changes, as folks are potentially turning to food as a coping mechanism to get through this. And 47% of respondents of the survey actually reported delayed or canceled healthcare services. So, taking this opportunity to kind of take stock on what we're doing, have we made sure that we've caught up on our own personal recommended preventive health care? Have we visited the doctor? Have we seen the dentist? And how safe is it for you to do so, given your own risk tolerance level and what you've deemed necessary for yourself with your primary care provider? So our physical health is really important to make sure that we're continuing to optimize during this time as well. And emotional health is obviously top of mind for many of us, as we heard in the question earlier, and as Dr. Wilson shared. All of us are experiencing this in a little bit of a different way. We're seeing that mental health overall has worsened as a result of this pandemic. There's an increase in stress. And right now, especially, and I think some of us might even be feeling this with the vaccinations kind of really ramping up. And what does this future state look like? There's a lot of feelings of concern about the future. In this particular study that was released, 49% of respondents reported feeling uneasy about this return to what is this new normal and re-engaging in human interaction, regardless of their vaccination status. So let's make sure that, we're continuing to provide support for ourselves, and ensuring our organizations know and our employees know that they have support available as well. And Tom Brown actually was referencing EAP. Many of our organizations offer an employee assistance program, and just make sure that you understand, if you do offer an EAP, what's available to your associates as a part of that. Is it access to counselors? Is it access to counselors face-to-face via phone? And then what other resources can your EAP offer to you? Can they do workshops virtually? Can they do trainings? Can they coach your leaders on navigating their employees through this crisis? Do they have financial or legal resources that employees can take advantage of? So Tom and I just wanted to make sure that you were aware of any resources your organization had to help support your employees as we continue to navigate and transition out of this pandemic into whatever the future holds. So that's just what I wanted to remind everyone about today, and then to also make sure you're prioritizing your own mental and emotional well-being during this time as well. And Stephen Gibson, I'll turn it back to you.
Right. Well, I know we're a couple minutes over our time. We're happy to field any questions. Otherwise, we are done with our part of the presentation. So are there any questions for us?
Can I ask one more? I just have a question on, we've vaccinated teachers in Ohio. We've prioritized teachers and healthcare, and now, it's being rolled out. What about children? Is there going to, we know that they haven't been as affected. Some of them, we know kids who have gotten it, but the severe cases of children is so low. What do we think about that?
So is it okay if I take that one, Steve? Okay.
Absolutely.
Okay. Didn't think you'd mind. Right now, there's some ongoing studies down at Children's Hospital and probably across this region for the Moderna vaccine, and then also the Pfizer. Now, the Pfizer actually is approved down to 16 years of age. I anticipate that probably some of your high school students, 16 and above, certainly they can get it now if their parents wish them to have it. We probably won't have the results of some of the pediatric studies until probably late fall, early winter. So those probably won't be done, administered until probably January, February. But based on some of the information we have, particularly those kids that are like 12 and below, seem to be not as an important a factor of spreaders of the disease as some of the teenagers who are more adult-like. So I think the emphasis will probably be on the teenagers first, 13 and above, before getting the kids. But I think there's definitely some interest in completing these studies and seeing how safe it is in the kids and how effective. And it's interesting because it's on the media, because I had a patient 12 years old come in to me and ask, do you get $1,000 if you get in that vaccine study? I was like, I don't think you get $1,000, but you probably will get some monetary compensation, but kids are paying attention.
And I guess, Stephen, I have one more for you. I think that Kroger came out a while ago that said something about giving a bonus to people. Can you field any of that? Is that an acceptable practice for vaccines, or is that just is that a no-no, you think?
So that's a great question. There are organizations out there hitting the media that they are doing incentives. If you go anywhere on the Department of Labor, EEOC websites, they have not published a stance on that. So you can hear differing opinions out there, but I would say any organization thinking about doing that, absolutely work with your legal counsel, because it is not black and white as far as what can and can't be done, even though some major organizations are doing it. So hopefully there will be more of a stance moving forward, so that can be a little more clear for employers.
Do you feel like a lot of people are doing, or what you're hearing is a similar program to what they have for the flu shot? Because, I know there's some places that require you to have a flu shot, but then there's some that they encourage the flu shot. Does that kind of seem like the same guidelines that they're coming out with?
Yeah, it seems like most are aligning. I know for healthcare, for example, when we first were able to vaccine, the vaccine wasn't readily available. There weren't enough doses for everyone. So in order for it to become mandatory, that was kind of a hard stance at the front end to say, let's make it mandatory, but we don't have the supply to even give it to everyone. So that was one factor when people at the very beginning started making their approach. I think more and more organizations will align to how they handle the flu vaccine moving forward.
And I know there's a lot of people who say, well, if you have a vaccine, then same as travel, you can travel, or you can come back to the office certain days if you're vaccinated. I think that that's part of the, maybe there are stipulations. It's not so much a change in what you can do or what your job is, but it's what you can do with your job. Is that, or in the office, I guess.
Yep. I think we will see a lot more hybrid work models, where people may come to work a day or two, work from home. Work from home has been a topic for years, and this kind of forced the issue for a lot of businesses, and they came to find out this works. So I think we'll see a lot more work from home or hybrid models moving forward as people get vaccinated.
Anybody else have any other questions? I'm always good for questions. Chris does. Here he goes.
A question, maybe a comment too, but probably for Dr. Wilson. In terms of the vaccine and getting it, and I'm the same age as you, and I've had the vaccine, so I'm coming at it from a position of support. Mm-hmm. But what I've seen is, like, from the CDC and what you see on the news, it's like you can get vaccinated, but you still need to wear a mask. You still should stay home. You still shouldn't travel. And I feel like that advice is not. It doesn't help people on the fence decide to get a vaccine.
Yeah, I think the CDC recommendations are going to evolve, and are going to be evolved toward allowing people who've been vaccinated to do more. I think you've already seen some of it where they say, if you've been vaccinated and you want to hang with other people who are vaccinated, you can drop your mask. You don't need a social distance. Or if you're going to be around people who are low risk, such as grandchildren, they can come in and you can hug them and squeeze them. I think there are incentives that are coming. I think the CDC is moving slowly because one of the reasons is people are getting vaccinated and then they're going and doing whatever they want to do anyways. So they don't want to open the door and say, well, you can do everything, and then more people will. But I think those recommendations are going to be coming forth. And I think that will incentivize people to do things. But I do think that there are going to be some, people are going to have to make choices. And I think traveling is probably going to be one of the choices. Certainly, if you want to travel out the country, if you don't have a vaccine passport, I think you're going to be required to get a nasal swab, probably at your own cost, in order to enter a country, or to get on the plane. I think with hospital systems, it's probably going to mirror the flu vaccine, but also, if you don't have the vaccine and you cough or you have a little sniffle, you might be sent home. So I think there are going to be ways that they're going to encourage people to get vaccinated, because we've seen what happens when you have a population that's not vaccinated, and it's just devastating to the society.
Thank you.
But I think that's coming.
Can you hear me, Mr. Bratton? Do you have a question?
Yes, Nancy, thank you. Dr. Wilson and Mr. Gibson, do you guys have an kind of building on that? When do you see travel, I don't want to say necessarily returning to normal, but domestic travel and then international travel? It seems like we're getting closer to being able to do some domestic travel. International travel still seems way up in the air as to when that's going to return, and just your thoughts on those.
So I think, unfortunately, there's already been a lot of domestic travel, as we've seen on TV down in Miami, other places, which does concern me. My big concern is if we can get through April and get more people vaccinated, I think by the summertime, you'll be able to see more and more people travel safely and comfortably. Now, I still think you're going to be wearing a mask on the plane for a little while, but I think you would feel more comfortable going someplace and being able to see relatives. International travel, I think that's probably late fall, probably even into 2022. And again, I think that's going to require testing and vaccine. I know someone who's actually supposed to be traveling to Sweden in June, and he's already been vaccinated, but he's already been told, you've been vaccinated, but you still need to get a test. I think particularly in Europe is really, really concerned now with the rising number of cases. So international travel is going to be a little tricky, but I think that's probably late winter, maybe early 2022 when some things open up. But domestically, I can see some of that happening in the summer and the fall. Actually, it's happening right now. It's just not advisable.
Anybody else?
Looks like Joanne Lee.
Yes, I just had a couple of questions. I'm scheduled to get my second vaccine on March 31st at Mercy Hospital. And by the way, I just wanted to tell the Mercy Hospital, if people that are here, that you did a great job and it's a great location. And I just happened to walk in and get one the one day, just going to copy the phone number down. So I got lucky. But on the 31st, I'm scheduled to get my second vaccine. And my question is, when are you considered, fully protected? I heard like maybe a couple of weeks after. And is it something that they recommend that you get at the same time the next year? I wasn't really sure.
Yeah, so right now, the thought is it's 2 weeks after your second shot, or in the case of the Johnson & Johnson, 2 weeks after your first shot, that you are fully vaccinated and have some immunity built up. So that's at the time when, again, based on current CDC recommendations, can get together with people who've also been fully vaccinated and not necessarily have to social distance and wear masks, and particularly getting together with other people vaccinated indoors, and getting together with low-risk individuals without having to worry about social distancing. As for a follow-up vaccine, I'm pretty sure, at least for the next couple of years, we're probably going to need booster shots. I think the data on that are not completely clear yet. So I know that's an ongoing study, and they're going to be checking to see the durability of the antibodies and making sure people who are vaccinated don't get infected, or if they do, that they have mild disease. So I think there's more to come on that yet, and we'll probably know more about that in the fall. But at this point, I would bet that we probably are going to need another vaccine next year. And Nancy, I could stay on as long as you need me to. I don't have any patients this afternoon, so if other people need to leave, I'm happy to stay on and answer questions.
Rosalind, do you have one?
Yes, I do.
Okay.
Here in Forest Park, they're traveling to either the Cincinnati Health Department or they're traveling to Hamilton Public Health. And they're also having a hard time getting vaccinated and getting appointments and navigating through the system. Are there any talks about partnerships with Mercy? It's a lot closer. It's like 5-10 minutes from a lot of our residents. Instead of having our residents travel, is there any conversations or any opening things up to surrounding communities?
So I don't know if, can you answer that about just the availability of the vaccines? Is that what it was kind of hard to hear you. Okay.
I'm sorry.
I can take a little bit of it, Stephen, and you can follow up on some other things like that. So I know, I think the week of the 30th and the 31st, there is going to be a larger vaccine venue up at Jungle Gems, which is a little bit closer. And we can get the number to register for that. I know that there are some talks about doing some pop-up vaccine places around Forest Park. I don't know what the details of that yet are, but I think there's a lot of advocacy going on to try and make sure that this community does get access to the vaccines that are necessary. So yeah, there should be more to come, but I know the closest one in timing is, I think there's going to be a vaccine clinic up in Jungle Gems.
Yep. So for Mercy Fairfield, we have been working with some community businesses that have large event centers because we're actually getting to a point where we're getting quite a bit of doses in, but we're actually running out of physical space to be able to socially distance people as they're getting the vaccine. So we have the staff, we have the vaccines that we're getting now. We're just trying to navigate that physical space so that people can safely get them. And we can get larger numbers through. So Jungle Gyms is a beginning of that. And we've been speaking to a couple other venues that are opening their doors to us to see where else can we go and open up that capacity.
Thank you. Please consider the city of Forest Park. I know we're trying to have conversations with Hamilton County Public Health to get access to vaccination clinics. And I know our mayor and city manager let them know that we can find space if we had that partnership to get that access to our residents and clients and nurse practitioners, so clients and residents. So, but yes, I think that we would partner to make sure our residents have access.
Great.
I think I would encourage anybody to sign up through the Hamilton County site, make sure that they're on that list. I think that that seems to be it was a good thing for me. And then even talking to your doctors, I guess all of you have lists probably from Mercy that you can direct them through there. But public health Hamilton County Public Health, I think, was doing the pop-up clinics in different areas too. And that was how if you signed up online, they were supposed to send you an email that said, you're on the list.
Hello. Everybody hear me?
Yeah.
Sorry about that. This is Aaron Brown. I'm a city councilman in Forest Park. I actually wanted to have follow up to that sentiment for the pop-up clinics. I know that the county is in discussions right now actually about having a mobile van. I wonder if Mercy thought about possibly retrofitting one of their vans. I don't know if there's like the breast cancer screening vans that could be used to instead for like a pop-up clinic to distribute vaccinations. I don't know if that has been in discussion, because I know the county is talking about getting one of those vans right now.
So from and Dr. Wilson, I'll let you chime in. I have not heard that, but that absolutely does not mean the conversation's not happening. From a region standpoint for Mercy, I know for Fairfield, for Fairfield Hospital, we're trying to find that space where we can have people come through. But I think that's a great point. I'm happy to bring that up. I can't answer if those conversations are happening regionally for Mercy.
Yeah, and I know there's some conversations, I don't know if it's necessarily a van, but having a site within the Forest Park Fairfield community that we can give the vaccines. One of the challenges that we have with it is, particularly with and we didn't talk a lot about this, but with the Pfizer in particular, but also the Moderna vaccines, they have to be stored at such a cold temperature that it's really difficult to transport them. That's why there's been a lot of hope with the Johnson & Johnson vaccine, that if we can get more of that, and there's been some manufacturing challenges, so we haven't gotten as much as we wanted. But once we get that, that can be more of a mobile vaccine, and that's something that we can take within the community, because one, it's only one shot, so we don't have to worry about scheduling people to come back, but also it can be stored at more refrigeration temperatures. So I think once we get more of that vaccine, I think that would be an opportunity to do that. But we've struggled to get a lot of that Johnson & Johnson vaccine because they've had some manufacturing challenges. So unfortunately, the clinics have had to be where you have the big cold storage refrigerators, which is the hospitals. But there has been some conversations about moving it out into the community.
I have a question of Alfie Jones. The vaccines that Mercy are carrying right now, are those dedicated for Butler County residents, or can they cross lines? I know in the beginning it was pretty much limited for those residents of those counties.
Oh, trust me, there's a lot of people in Forest Park who cross the line to go to Mercy. Yeah.
Okay. I just want to make, because I hate for someone to go up to Mercy or somewhere to apply, they get turned away.
Yeah. There's we don't respect that county border, so there's a lot of people from Forest Park that have gone up there.
All right, Dr. Wills, I got a question for you. I hate to carry this on any further, but you had a chart showing where the disparity between minorities and the Caucasian population, and as we got older to the 50s and up, the disparity was about, it wasn't much of a disparity.
Right.
But looking at the 18, I think it was 18 to 49.
Right.
Would that be true for the flu vaccine? And then would that be true for those groups having primary care physicians?
That's a good question. I'm not sure if it's true for the flu. I would have to imagine that it's probably very similar. And I think one of the things that I've had some conversations with some of my colleagues, particularly who are younger, about how we can motivate particularly our younger population to get the vaccine. And again, one of the strategies I've seen is basically encouraging people to get the vaccine to protect their loved ones, the grandparents, uncles, aunts, and so forth, using it as kind of a sign of love that, hey, I'm going to get vaccinated because I don't want to carry that to you. But also getting a lot of younger people in the community who influence the community to get them to take it. Like one area that I think we have underutilized, particularly in our community, is barbershops and hair salons, because everyone goes there. They're already considered experts in a lot of medical areas, even though they don't really have medical training. But a lot of their clients listen to them. And I think if we can reach out to them, educate them, they could actually be the voices for getting people vaccinated. And there's a lot of science behind that. Up in University of Maryland, they've been doing that quite a bit in that College Park area, reaching out to barbers, hairstylists, and educating them on colonoscopy screenings, getting mammograms, and now COVID-19 and the vaccine, to use them as a way to influence the population. And I think those are kind of things we're going to have to do. We're going to have to get people on TikTok getting vaccines. We're going to have to get people on Facebook, although my son tells me Facebook's for old people. We have to get people on Instagram. And I think one of the reasons that you've seen the numbers improve from where they were is because people have been very public about getting the vaccine. I remember when I got mine, I took a picture of my vaccine card and put it on Facebook and shared it with all my friends. Now, I was stupid and didn't cover up my date of birth, so I had to take it down, put a new one up. But I was surprised how many family members and friends reached out to me and said, well, I was going to call you about the vaccine, but I guess I don't need to talk to you. I'm going to set up my appointment next week. and that's kind of how I was. I talked to a couple of our ID specialists that I really respected before I got mine, and I saw they were getting it. They were sharing some of the data with me, some of the history. I did some of my own research, and I said, this is something I need to do to protect my family. I mean, I want to hug my mom, who's 82, at some point, and not feel like I'm going to be transmitting something to her. So I think getting people in the community who have that influence and have that platform, getting them involved. And I think with young people, that's what we're probably going to have to do. And I think you'll see it change, because I think, again, children want to hug their grandparents. They want to be able to hug their parents and feel like they're not putting them at risk. And while they may not want to do it for themselves, they'll do it for others. And I'll just give you one example. It used to be the other way with the pertussis vaccine, where we needed to make sure that babies were, because they couldn't get vaccinated, make sure that everybody who was going to be around them had their pertussis vaccine, so they wouldn't get pertussis. And I had one patient, he just refused to get his pertussis vaccine. And I happened to see his son and his daughter-in-law. Well, they had a wonderful, beautiful baby girl. And his daughter-in-law was like, "You're not holding my daughter until you get your pertussis vaccine." And he was in there 2 days later with his arm. Now, he was grumpy. And he didn't want to get it, but he wanted to hold his granddaughter, so he got it.
I have a mom who can't be around my daughter unless she has her flu shot too. So she gets her flu shot every year. And my daughter's immune compromised, and so my mom has to be around her. So there you go.
Yeah. I mean, that's
So
you do it for others.
They do. And I think if we incentivize people by not having to wear masks or do some certain things, like Chris said, I think it would change a lot of the under 40-year-olds. They really.
And I think the more people that get vaccinated, the closer we'll be to getting rid of the mask. Yeah.
Right. Well, I want to thank you so much for all of your time and your information. I so happy that you were here, and it was wonderful. Thank you to Mercy, Stephen, and everybody that was here today. I think we had great information. We will post this recording on our website. We'll send it out to our membership, and they will be able to click on the link and be able to see the video. And we'll also take the slides and do the same thing if that's okay with you. Because I think it was a wealth of information that we need to get out to as many people as we can. So we will do that and drive people to it, and it'll be shown on Waycross over a couple different times. If you're up at 2 o'clock in the morning, sometimes we're on. You never know. I don't know what time we'll be on there, Chip, but they will broadcast us. So thank you again. And if anybody has any other questions, hopefully we will be in person soon, and maybe we can have you come back and talk about the success of everying. How about that? That would be a fabulous follow-up, wouldn't it be?
Thank you.
In person in the fall, that we could all be back in person and say we did it. We were better than we thought we were. So, but I want to thank everybody for being here, and just to let you know too, good news, our scholarships are due, our scholarship applications are due, and I've been interacting with a couple of the scholarship kids today. So we will be, having all of those come in this week from our wonderful school kids over at Winton Woods, and in their beautiful new school building, which we were able to be there for the ribbon cutting a couple weeks ago, and it was wonderful, and everything so we're all going to be back in person and back to some level of new normal soon. So stay tuned. We are going to be back together in April. Won't be around tax day because tax day got pushed, but we will try and get you some more information on when we will be all back together again shortly. So again, thank you very much. And everyone have a wonderful rest of the day.
Thank you.
And week. Okay. Thanks so much.
Thank you.